right, so we were a little bit late. Here I am. I'm Dr. Alice Lee. Welcome to iCubed episode 20. No, wait, it's 35. It's 35 already, almost 3 years. I want to welcome you to ACEP 2019. We're here in Denver, Colorado. It's going to snow tonight, and I haven't seen snow forever. I want to welcome a special guest. I know I say a special guest every time, but this is a very special guest. Dr. Evie Marcolini, welcome to iCubed.
Alice, I couldn't be more excited to be here. I'm really in awe of what you've done with your series. So thank you for inviting me.
Well, you're so kind. Now, could you introduce yourself a little bit?
Yes, I'm Evie Marcolini. I am an emergency physician and a neurointensivist. I work at Dartmouth in the mountains of New Hampshire, and 50% of my time I'm in the ED, 50% of the time I'm in the neuro ICU.
Wow.
And it's a great combination because I can bring that neuro patient right through the whole process, and it's a great opportunity.
So this case is perfect for you.
Great.
So let's just dive in. I wanted to talk to you about this case because I'm really curious about your thoughts. All right, so Evie, I work in a mainly geriatrics emergency department. Mm-hmm. So the vast majority of my career, which is a long career, are senior citizens, and we have a stroke center. So this is a patient that came in a little recently. She's 93 years old. She was out with her daughter, and she has a history of atrial fib, history of a pacemaker. She has a distant subdural hematoma and a history of TIAs. She came in with the acute onset of left-sided hemiparesis that was witnessed by her daughter while in a car. Okay, this is approximately 30 minutes before she came in. She is normally alert, independent, lucid, functional, 93-year-old. And we see a lot of those in Arizona.
Yeah.
So the daughter says they've been out riding their bicycles, the patient in her tricycle, the patient's daughter in her bicycle.
Wow.
And, yeah, exactly. And so they put the daughter says, I helped mom put away the bikes, and we got in the car because mom wanted to go to the store. On the way to the store, the daughter said, well, my mom wanted to go to the bathroom, so I stopped the car to go to the bathroom, but I couldn't get her out of the car. So that's when she called 911.
Interesting.
Yeah, so that's what they get, and I see her in the scanner. She's literally on the scanning bed, and her head's turned to the left, okay? Here's her blood pressure. 171 over 107, heart rate is 78, her heart rate is 16, respiration is 16, her temperature is 36.7, and her stats are 99. She's awake, she's alert, and she's actually conversant. She has a fixed leftward gaze. She follows my commands. Her speech is just a tiny bit slurred. It might be an overcall, but sometimes it's just very, very subtle. She has a very minimal left nasolabial flattening, slightly. I ask her to raise her arm. She lifts it. She kind of wavers and drifts. I ask her to raise her left leg. She lifts it. A little bit longer, but it wavers and drifts down, okay? The stroke nurses are in there. They tally up the NIH score. It's 10. Okay. So immediately she's in the scanner. I'm saying she's got left-sided deficit. I'm going to just go ahead and order the CTA right on the table. She's there, right? So the CT brain comes back negative. And here comes the difficult part, and I'm very curious of your thoughts. So the nurses, the stroke nurse and I were talking to the family. There's a daughter, there's at the bedside, there's a granddaughter, and then the patient asked me to talk to the MPOA, which is another daughter, on the phone who's not in state. So the timeline at this point of the discussion is roughly 75 minutes-ish from the onset of the symptoms.
Okay. So now you've got a 93-year-old who clearly has risk factors.
Yeah.
I think I recall you saying that she had prior TIA,
yes,
atrial fibrillation. Is she on any anticoagulation?
Nope, not on any anticoagulation.
And she's got a pacemaker. And multiple other comorbidities that a 93-year-old person would have. And now you have a CT and a CTA.
Or negative.
And it's interesting because you decided to get the CTA right away. I know you're supposed to be asking me questions, but how do you guys decide who's going to get a CT and who's going to get a CT-CTA?
So this was a while back when we didn't have a really established kind of protocol. Nowadays, it's more if the patient's VAN positive, then we do the CTA But this was a few years back where there was not such an established protocol. So for me, it was more gestalt. She's got hemi, an entire left side is kind of out. So I just thought, let's just get it. She's on the table. We're in a time crunch. Let's just a CTA, and have the radiologist look at it in case there's something we can do endovascularly.
That's good, and I'm glad to hear that you're using the VAN protocol because I think it's really useful.
It's very useful.
Question that so many people have. Am I going to get a CTA on every patient who comes through as a stroke alert? And that's clearly unreasonable.
That's right.
But how do we differentiate? How do we decide who's going to get it and who's not going to get it? At this point, you're talking with family on a re-exam after the imaging. Does she still have those deficits?
Yes. Great question. Great question. Same deficits, same level of weakness.
Okay. All right. Now, it's tough in a 93-year-old
Very hard
to think about giving TPA, isn't it?
Yes.
Right? And you want to be careful. Not that we would be cavalier about giving TPA to a 63-year-old or anybody younger, but that is tough. The good news is that you're close to the last known normal.
Yes.
So the quicker you get TPA, the lower the risk is of a spontaneous intracerebral hemorrhage, which is the thing we're all concerned about, especially in a 93-year-old. But it's still concerning.
It's really agonizing. Every time I have a discussion with family about TPA, I was on the phone because the patient wanted me to talk to the MPO. It was an older daughter.
Sure.
So I'm on the phone explaining it a second time, and about the time window and what we do, blah 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 blah. And the MPOA says to me on the phone, she says, "What would you do if it's your mother?"
I love that question.
What do you think? What would you say if this was your patient?
Yeah.
And the daughter asked you, what would you do?
I'll be honest with you. With somebody that's that old, that has that many comorbidities, I know we're in a time crunch. You know we're in a time crunch.
Right.
And if we're going to give TPA, we want to give it sooner than later. But something about this picture... Was she in a sinus rhythm?
Yeah, she's a pacer. She was in a pacer.
Pace?
She has a history of atrial fib, but she's in a pacer.
Rhythm.
She's not a pacer.
Okay. Did you have any discussion with either the patient or the daughters about her wishes and the risk of giving TPA? And, okay, we know now that the risks are lower if you give it earlier.
This is like 75 to 90 minutes. This is around that time when we're having this long, drawn-out, agonizing talk. Daughter on the phone, granddaughter. Granddaughter says to me, aren't you supposed to give this early if it's going to work? We had this, the patient, it's a good question because the patient is pretty lucid.
Yes.
She says to me, and the daughter's asking the patient, what do you want to do, Mom? What do you want us to do? The patient says, I want you to ask Dr. Sung's opinion, her cardiologist.
Okay.
Because he had just put in a pacer. So, patients have their devotion and their, So I said, I don't think he's going to contribute to this decision making, but they still wanted me to ask the cardiologist. I was like, okay. So I step out of the room to put a phone call.
Yeah.
So I step out of the room, and this case demonstrates what I've said many times. It's better to be lucky than smart, because when I step out of the room, the nurse calls me back and she goes, she's having a seizure.
Get out of here.
Yeah. So I go back in the room and she's having a partial complex seizure.
Perfect.
Her left side is clonic jerking. Patient's alert. I can talk to her during this. And then the daughter at that moment says, oh yeah, she was really stiff in the car.
I think you're right. It is. That is very.
I'll show you right here. This is the time table. Okay, so she was approximately started to have the left side of weak. That's 12 o'clock. She gets to my ER at 12:30. I'm in the room in 7 minutes at 12:37. We start having a talk at 13:14 about the TPA. I go out to get the cardiologist page, and at 13:35, which is 95 minutes, she has a seizure. This is all documented in the chart. So obviously, with her having a seizure, I'm like, oh, I'm so glad I didn't give a TPA.
Yes.
And we can talk about that also.
Yes.
But anyway, so my immediate reaction was, oh, God, so fortunate I didn't give that TPA, because I was like really wrangling with that idea of giving a 93-year-old TPA.
Alice, that is a really tough case, and I'll tell you something. A couple of things. First of all, we are very anxious giving TPA to a 93-year-old. Even if we saw thrombus in one of the vessels, we're very anxious about taking those folks to angio.
Yeah.
And understandably so.
Understandably, yeah.
And I think it's great that you pursued the conversation of what would she want. And I'm sure you described the risks and the benefits. I have had neurologists tell me that TPA is not really a consentable thing because it's the standard of care, and patients, we don't really have enough time to go through the consent process, but it sounds like you did it very diligently, and I think that's appropriate. And it's what we do well in the emergency department. We connect with people quickly, we ascertain where they're at with their understanding of their disease process and what's going on, and we can explain to them and get them to understand what are the risks and benefits. And that's what we do well.
Yes,
right?
Because we're in the trenches. We are there when they come in.
And the second part of this is, I don't know why I was so anxious about just give her TPA, but we do have to think about mimics. And I'll tell you, I had a case of a very young person who had a stroke from a dissection 7 years earlier.
Okay.
And came in.
Carotid dissection.
Carotid dissection, yes. 7 years earlier, came in with stroke-like symptoms. And we stood around the bed, neurology, the stroke team, emergency medicine, and we were starting to consent her for TPA. And while we were standing there, her leg began to twitch. And I said, "What's going on with your foot there?" And she said, "I don't know, I'm not doing that." And we started thinking about seizure. And one of the things that we have to realize is that if you have a lesion to the brain, whether it's a stroke or subdural, she may have had some encephalomalacia or some kind of change affecting the parenchyma of the brain from that subdural.
Yeah, exactly.
That's vulnerable tissue and can have seizures later, so we need to think about that. So anytime I see that there's a history of brain damage in any way, shape, or form, whether it's a bleed,
double think it,
subarachnoid, stroke, think about that seizure.
Okay, as you guys know, every single episode I have learning focus number 1 and number 2, and our very first learning focus obviously will be stroke mimics. So acute ischemic stroke, as compared to a mimic, there's a definition in the American Heart Association, and it's an episode of neurological dysfunction caused by focal, cerebral, spine, or retinal infarction. And I looked on their documents, and there's actually no stroke mimic definition, but their resource says clinical questions that need to be answered considering a stroke mimic is do the clinical deficits result from a vascular cause? Where in the CNS is the lesion, and what are the parent vessels involved? And what is the mechanism? Is it ischemia or is it hemorrhage? Well, let's go to a very practical definition. I found this with emdocs.com with Britt Long. So he says a stroke mimic is defined as a non-vascular disease that presents with stroke-like symptoms, often indistinguishable from an actual stroke. Yeah, that's what I think of a stroke mimic. So I looked, but I want to tell you the prevalence of stroke mimics is kind of bounces around. Like for instance, there's a study here out of Spain, 4,570 patients. Out of those, 8.8% mimics. And then here's another big study, probably the largest study about stroke mimics. It was out of Bethesda, and the Washington Hospital Stroke Center. It's 8,000 patients practically, 30% mimics. Then there's another one out of Mayo Clinic in Arizona. 206 patients is a little study, 22% mimics, okay? And then one out of Korea, a very large study, 4,673 patients and 48% stroke with 51% mimics.
Wow.
So the numbers differ because the definition of mimics differs slightly between studies and the inclusion is slightly different, So that's the prevalence of stroke mimics. Now, what are the common stroke mimics? Ours was a seizure and it's one of the top stroke mimics. Brain tumor, labyrinthitis, metabolic disorders, migraine headaches, atypical migraines, psychiatric disorders, sepsis, syncope, and transient global amnesia. What about stroke mimics that present as seizures? That's very relevant to my case. So the one study out of Barcelona, Spain, with the 4,500 patients and 8.8% mimics, actually 26% of the mimics were seizures. Another one, the Mayo Clinic study with the 206 patients with 22% mimics, 17% of the mimics were seizures.
As the emergency physician, what I like to tell people is the emergency department is where all the neurologic disasters happen. They come through the emergency department. So we are affecting the outcome of those patients. And in a patient like this, in particular, we're there to think about everything else besides the brain. When you're a neurologist, and you're a stroke neurologist, you're thinking about stroke, and you're thinking about the brain.
Only focus on the brain. That's right. That's their job.
Right, and I'm not saying they never think about anything else, but we are trained and we're good at thinking about everything, head to toe, and family, and everything else. So that's what we're good at, and we need to make sure that we are part of the process. I'll tell you that in many emergency departments, the stroke system is so well tuned. And it's great because the stroke neurologist comes down, the fellow's there, they're doing the exam, it's happening quickly, which we want it to. However, if we move too quickly, we're going to forget about the mimics. And the emergency physician needs to be a part of that process. All too often, when the whole stroke team comes down, I find the emergency physician is saying, okay, that patient's all set. They've got the stroke team taking care of them, and they go on to see another patient, which I maintain we should not do. We should be a very important part of that patient's process.
I love that perspective. That's a great perspective.
But we really need to think about all of those stroke mimics, and here's where it gets simple. You take that patient to the scanner.
Right.
That patient had a stroke syndrome.
Yes.
It's symptoms, which are clear.
Yep.
You saw that.
Right.
And the CT is negative. I don't care about that. The CTA was negative.
Right.
So now I've got a little pink flag saying, CTA is negative. I have to think outside the box here, because if the stroke syndrome was there and I saw the clot in the area of the brain that matched with that stroke syndrome, you're kind of done, right? But if I don't see that clot, I haven't really nailed it yet. It might be. That's why I asked, did your patient still have the symptoms after the CT? We really need to think about all of those stroke mimics.
Learning focus number 2. So why should we care about stroke mimics? Why? Why does it matter? Well, for me, primum non nocere. First, do no harm. So when the patient comes in to me, I'm always, with all of these TPA cases, I find them very agonizing because it takes a lot of time, and I'm listening to the patients, I'm trying to make the best decision I can for them. And especially in the elderly, it just makes me, it's just such a typical decision all the time. But I did find a couple of resources which were very nice that helps me feel more at ease with what decision making I do. So here's a study. It was analysis of Get With the Guidelines Stroke National Registry from 2010 to 2017. In that registry, 72 72,582 patients got TPA. The symptomatic intracerebral hemorrhages were 0.4% in the mimics, and symptomatic ICH was 3.5 in the strokes. So actually, symptomatic intracerebral hemorrhage was much less in the mimics in that study.
Hi, I'm going to interrupt for just a minute because just as I finished my recording with Dr. Marcolini at ASAP, Rebel EM published a podcast reviewing this exact same study I just went through. Salim Verzai actually was very hot under the collar about this study because he felt there was a lot of flaws in it, and then the conclusion really was not reliable. He went through many reasons for that, but a couple of the major ones is that this is a study that had a large reporting bias because the stroke mimic cases that were submitted was only optional. Not everybody had to submit the stroke mimic cases. And then the symptomatic ICH definition was really open to bias because this is an unblinded study. And then lastly, the analysis was really limited to larger hospitals because they required at least 10 Alteplase cases and 5 stroke mimics during the stroke period. So smaller hospitals were not able to or did not submit cases most likely.
Another study, it was a 12 European Stroke Center study. 5,581 strokes were treated with TPA. About 100 patients, which is 1.8%, were deemed stroke mimics. And there was 1% of ICH in the mimics, so one patient out of 100 patients, versus 7.9% hemorrhage in the stroke. So, as I read that article, it actually kind of made me feel better about if I had to, or if I did give the stroke mimic a TPA at the time, that the risk was very low, although not nil. What do you think, Evie?
I agree. It is somewhat reassuring that the mimics have a lower spontaneous intracerebral hemorrhage rate. However, we never want to be that physician who gave TPA to a stroke mimic. Now, I can't think of anything that has been more controversial in emergency medicine over the years than TPA for stroke, and for good reason. There are many problems with the literature, many problems with the studies, and then in 2015, we had all this evidence that told us that mechanical thrombectomy improves outcome in patients. That, together with the nationwide push for comprehensive stroke centers, has put us right in the middle of a very dynamic issue. And I say this because many hospitals are trying to become comprehensive stroke centers for good reason. We want our stroke patients to get the best and fastest care. However, in the setting of this decades-long controversy over TPA, we're in a position where now there's a really strong push for mechanical thrombectomy. And we're going to get 93-year-old patients who go to angio.
Yep, exactly.
And one of the things that we in emergency medicine, I bring it all back to the emergency department because this is where it happens.
Right.
This is where the rubber meets the road. We have to figure out the mimics, and we have to be smart about this.
Yes.
We have to understand all of the benefits and the risks of both giving the TPA or sending a patient to angio or not. And it puts a great onus on us. Yeah. So it's very complicated.
Yes.
But which is why I like to make it simple. You're working in the emergency department. Patient comes in with the symptoms of stroke. You get a CT, CTA. You get the urine.
Yes. We got the urine. Yep.
And then you read that and you say, okay, CT and CTA are both negative. What am I missing?
Right. And you got to think about
Sometimes you're not. Sometimes it's going to be stuttering. Sometimes you're going to have that. But these are important questions.
I think that speaks to the danger of making it too fast track, making TPA administration for stroke a automatic cookbook path, and I think that's really dangerous. And so we have to be very smart about it. And that's why I wanted to bring this case to my audience, to viewers, because I want us to think about these cases. They're very, very time consuming. I want us to understand there's such thing as stroke mimics and not to automatically just put it on the fast track for TPA. So my personal approach to TPA is I'm always thinking slowly with it. I always talk to the family, and I will give them my honest opinion. When the daughters asked me if I would get notice hesitation, no, I said no, I would not. But I also make it very clear that that's my opinion. We have to make this a collaborative decision. But my opinion, no, I would not. I would not. And then that was when the patient said, can you ask my cardiologist? So. Well, thank you, Evie, so much for joining me. I'm so excited that you were neuro.
Alice, it's been my privilege. I'm so excited
That's wonderful.
to be here. Thank you for asking me.
Oh, you're welcome. We'll do it again, okay?
Excellent.
All right, so thanks everybody for following this screencast, and thank you for watching. All right, we'll see you next month. Take care. Bye-bye.
Bye, everybody.